afternoon, everyone. So I think a lot of people in this room, but my name's Rachel Egan. I'm a consultant psychiatrist. I work with the mental health liaison team at Royal Stoke. And I was asked today if I'd come and give a kind of 30-minute presentation. I suppose there's a huge range of things we could have picked, but I thought with it being a prescribing conference that I'd focus on perhaps one area of prescribing, so decided to concentrate on the prescribing of Clozapine. So just a bit of background information on our team. We're a team of 25, we're probably up now to nearly 30 actually staff members. We provide a 24-hour, 7-day-a-week service, and we accept referrals from across all the departments at Royal Stoke, Haywood and Cheadle Hospital, excluding outpatients. We have response times and targets that we have to meet, so we see referrals in the emergency department within an hour. We have to go within 4 hours to portals, within 24 hours to wards. We aim to accept the vast majority of all the referrals we receive, and we aim to go and see all our patients face to face. We receive up to 700 referrals per month. We have around 1,300 or more face-to-face contacts per month. The number of beds at Royal Stoke was covered in this slide, 1,328. It employs over 6,000 staff. It's the third biggest hospital in the UK with 97 different services and departments. So it's a huge area that we're spreading ourselves thinly around. So the learning objectives for my presentation would just give you 3 interesting liaison cases, all involving prescription of Clozapine, to think about a kind of shine the spotlight on the safe prescribing of this drug, have a look at some side effects that we monitor for, and think about some considerations when these patients are coming into the acute hospital setting. I've also sneaked in 3 famous people who are said to have had schizophrenia, so if you can point them out at the end, then you'll get a bonus point. So I was aware that we've got people in the audience who aren't from a psychiatric background, so just to kind of give a bit of a baseline about, before we get into Clozapine, so about psychosis. So when a patient has psychosis, what we're describing is that they've lost contact with reality. It's where the dividing line between what's real and what's not real becomes blurred and intermingled. And the 2 main symptoms of psychosis are hallucinations and delusions, and it's the combination of these 2 that often leads to distress and altered behaviour. And as you can imagine, psychosis arising in a general hospital is often a source of great concern, and it's a source of frequent referrals to our team. If we're thinking about Clozapine specifically, then we're thinking about patients who have schizophrenia or treatment-resistant schizophrenia. So again, for non-psychiatric colleagues, really, I'm giving you here the ICD diagnostic criteria for schizophrenia. But essentially, we're still looking at that psychosis. The common feature to schizophrenia is that apparent disintegration between the boundaries between the self and the surrounding world. You can see lots of the hallmark symptoms are either hallucinations or delusions. Passivity is one that people might not have heard of, so I'll put that picture up there of almost feeling like you're a puppet on a string. So you're experiencing an outside control or an interference with either how you think, how you feel, how you're perceiving the world, or how you're behaving. Again, on the bottom list there, you can see we've got catatonic symptoms, and because that comes up with our patients, again, just wanted to draw attention to that. So catatonia is a psychomotor syndrome. It has motor, affective, behavioural, and autonomic components. What you might typically see in a patient with catatonia is unusual motor movements, so they might be rigid, mutism, posturing, waxy flexibility. There are motor features to that condition. The bottom one is formal thought disorder, so that's where there's disorganised patterns of thought. So if we think about schizophrenia in terms of Clozapine, schizophrenia itself is said to be treatment resistant in between 1/5 and 1/3 of cases. We define treatment resistance as the persistence of positive symptoms of psychosis, so those hallucinations, delusions, disorganised thought, bizarre behaviour. On average, it's 4 years before patients who fit that category are trialled with Clozapine in the UK. So the NICE guidelines on the prescription of Clozapine are that we should offer Clozapine to people with schizophrenia whose illness has not responded adequately to treatment despite the sequential use of 2 different antipsychotic drugs. They need to be of an adequate dose and an adequate duration. At least one of those 2 drugs should be a non-clozapine second generation antipsychotic, and in practical terms that drug should be olanzapine. Clozapine in this patient group is said to improve outcomes for up to 50 to 60% of patients. Now, clozapine, it's a second generation atypical antipsychotic drug. It's got interactions at a myriad of neurotransmitter receptors that I'm not going to kind of take us through, but essentially the key areas are that it's a blockade of the dopamine 2 receptors. So blockade of dopamine 2 is said to reduce the positive symptoms of psychosis and also to stabilise some of the affective symptoms, and they will be our negative symptoms of psychosis, which can be things like anhedonia, apathy, social withdrawal, affective blunting. It also causes blockade at serotonin 2A receptors, and again this is said to enhance dopamine release in certain parts of the brain regions, which would then reduce some of the motor side effects of this drug. And again, that can lead to an improvement in cognitive and again those affective symptoms. So just some basic bits on clozapine that probably you all already know, but it's a tablet. You take it 2 times a day, so your dose is split, and you normally give the larger dose at night because of the fact that it is sedating. It needs to have blood monitoring, and therefore you have to be registered with a blood monitoring service before you can begin to take this drug. There are 3 clozapine blood monitoring services in the UK: CPMS, CTAS and DMS. Most of our patients locally would be under CPMS. When you initially start this drug, you have to start at a very low dose. You start at 12.5 milligrams, and then there are set titration schedules where you'll increase in steps up to around 300 milligrams per day, usually over 2 to 3 weeks. You can then have further dose increments of 50 to 100 milligrams per week. I put up on the slide the therapeutic range. So when you take a serum plasma concentration, the therapeutic range is between 0.35 and 0.50. Now that range can easily become toxic, especially in drug-naive patients. So that's why it's important that we have good concordance from the patient in terms of taking that drug and in terms of engaging with the therapeutic monitoring. If you miss a dose of clozapine, you've only got a 48-hour window to get the drug back in. Beyond 48 hours, because of the risk of toxicity, you have to retitrate from that initial baseline dose. A couple of other things I've put on the slide are about the dose range. So it's impossible to say what different patients will need different doses of that drug, and that's going to depend on their gender, it will depend on their age, it will depend on what other medications they're prescribed, and it will depend on whether they are a smoker or not. Many of the adverse effects of clozapine are dependent on plasma concentration. So as I've put on the slide, it's important to monitor plasma levels, especially following initial titration or dose changes, but also after a change in smoking habit. And I'll draw attention to that in one of these cases. In terms of the blood monitoring, I put that on the slide. So we have this traffic light system. The blood monitoring is mandatory, and we would do it weekly for the first 18 weeks that you prescribe this drug. Then you drop to fortnightly for the whole of the first year. After that period, you'll have your bloods done monthly for the duration of treatment with clozapine. And the bloods will be reported in a red, amber, green system that I've put on here. So the traffic light system, you give your bloods, you report it to CPMS, and then you'll receive either a green light, which is to continue with clozapine, an amber light, which means that either your white cell count or your neutrophils are falling into that amber zone, and if you get an amber, then you'll be increased to twice weekly blood monitoring until we're back to in green status. If we get a red light, then we have to stop immediately, and it goes to daily monitoring, but also consideration of does that patient need to be in hospital. What the monitoring is looking for is the side effect of agranulocytosis. And what agranulocytosis describes is the neutrophil count, and it means that there's an absence of circulating neutrophils. The neutrophil is the most abundant type of white blood cell in the body, so it's the first line of defence and plays a key role in immunity. So you can imagine if your neutrophils are dropping to these dangerously low levels, then the risks are overwhelming infection and sepsis. Agranulocytosis is much more common during the initial initiation of clozapine, hence why in those first 18 weeks is the period in which you will monitor the bloods the most frequently. Now, there are a whole host of other side effects of clozapine, but I was conscious of time and haven't got time to go through them all, so I wanted to get into my cases really. So the first case I'm bringing to you is Sid. He's a 37-year-old gentleman. He's been admitted to Royal Stoke. We're going back to 2023, and he's collapsed and he's got postural hypotension. The diagnosis that's made, he's got quite a complex sort of foot injury, and he's got a severe right foot cellulitis. He's also anemic. You can see on the slide he's on IV antibiotics, there's a blood transfusion, he's having all sorts of further investigations. The referral comes to Mental Health Liaison because of an incidental finding of an elevated clozapine level. So his clozapine level was 1.67, and I've put the reference range again there. It shouldn't be greater than 0.50. Like you can see on the bottom of the slide that he would still fit into the green light in terms of his white cell count and his neutrophils. Now, there were no particular symptoms or concerns about toxicity, but if we're considering clozapine toxicity, the type of symptoms that you're looking for, the hallmark one is sedation, so an excessively drowsy patient. Other symptoms of clozapine toxicity are hypotension, hypersalivation, constipation, but you're also, when you're in that toxic range of clozapine, you're at risk of neurological adverse events, so things like akathisia and seizures. It also causes prolongation of the QTc. So at the period that we've seen Sid, he's not got any features of toxicity, but we've found a toxic level. He's also not opening his bowels. So just a bit of background on him. He's a gentleman, he's got a diagnosis actually of schizoaffective disorder. He's known to the community mental health team. He's been stable on clozapine since 2013. And you can see on here, he's on a relatively high dose. So he's on a total of 625 milligrams per day. I put there his kind of relapse signature. At the point that we saw him, he had no signs of relapse psychosis. So the thoughts around him, the initial thing was, is that sample actually a trough level? So when you're taking a clozapine plasma level, it needs to be trough, so it has to be 12 hours post-dose. So we check is it trough level, and it was. The next thing to think about was change to smoking status, as the coroner already alluded to. So this gentleman had had a major change to his smoking status. In the community, he's smoking 25 cigarettes per day. In hospital, he'd had absolutely none for 2 weeks because he'd been so unwell. And at the point that we'd seen him, he was then having between 2 and 4 per day, which was just when he could be taken off the ward. So what we know is that the smoking habit has a massive effect on the metabolism of clozapine, and it can mean that you need up to 50% less of the dose on average. Clozapine levels can rise by 70% in people who just suddenly stop smoking. And this is because of the polycyclic aromatic hydrocarbons that are present in tobacco smoke. They are enzyme inducers. So clozapine is hepatically metabolized, and smoking induces the liver enzymes on the P450. So what smoking will do is it means that the P450 enzymes metabolizing the clozapine in the liver are working that much harder, so it will pass and metabolize the clozapine quickly. So when you suddenly stop smoking, there's a rapid and exponential decrease in those liver enzymes in their activity. And it means that we stop smoking, the levels of these cytochrome P450 enzymes fall, and then suddenly the serum levels of the clozapine starts to skyrocket. When we've got high blood levels, we know we're at risk of toxicity, and I've already gone through the symptoms of that. What we know with smoking is that when you've had a change to smoking, those enzymes and the change in their activity will come to a steady state after roughly 1 week. So the advice would be that if someone changes their smoking status, that you repeat your clozapine levels after around 2 weeks, because by then the clozapine levels should be stable again. If people are smoking between 7 and 12 cigarettes a day, then there's no need to make a change. But above those levels, we do need to change the dose. He's also constipated, but I'll pick up on that with the next case. So our management was that we reduced his dosage by 50%. We also spoke to the ward about managing constipation, made it clear that and explicit those signs of toxicity that we needed to monitor for. We did an ECG. We also made clear to the ward what his relapse signature would be, because suddenly you've got a man who's going to be on half his normal dose of his antipsychotic. And we also repeated the level. So we did it sooner because of how high that toxic level was. So we repeated after 5 levels. And again, it was still super therapeutic, but it was much less than that first one. So the learning outcomes from that case, really, that I wanted to sort of draw your attention to, is that reference range for clozapine levels, and that when we go above 1, that's when we're really concerned about toxicity. Again, just making clear the signs of toxicity: sedation, hypotension, hypersalivation, seizures, non-QT. It should be a trough level when you're taking a clozapine level, so 12 hours post-dose. You don't need to make any changes if people are smoking between 7 and 12 cigarettes a day, but above that you do need to, and that might be to drop the dose by roughly 50%. So, I see I'm doing time. I'll move on to the next case. I'll take hopefully any questions at the end if I have time. So I wanted to go on to our next case. So this is a lady called Zelda. So she is 62 years old. She's known to the community mental health team, and she has a diagnosis of schizophrenia, but she has catatonic schizophrenia. So when she's unwell, her symptoms are of altered motor activity, including repetitive movements, posturing, stupor, and rigidity. What we know of her is that when she is well, she's very talkative, she's described as the life and soul of the party, has very good relationships with carers. But when she's unwell with catatonia, she'll become mute, immobile, and completely withdrawn. This lady is on a long-term, again, another long-term stable patient on monthly monitoring, and her clozapine dose is in a lower range than SID, so she's taking a total of 425 milligrams per day. She's not a smoker. Alongside the clozapine, she's prescribed a low dose of amisulpride, so another antipsychotic drug, and procyclidine, so an anticholinergic drug often used for the extrapyramidal side effects of antipsychotics. So when Zelda comes into the hospital, she's been generally unwell, back in 2020 pandemic, generally unwell since the end of June. We know her last bloods are a green light, everything's fine with clozapine. The symptoms that she has, and I did put it slightly wrong on the slide, so she had a distended abdomen, her bowels had not been open, so the diarrhea bit's wrong. Her bowels weren't open and she was vomiting. What the carers said is that before she came to Royal Stoke, she had multiple days of constipation, she got abdominal pain and her abdomen was distended. She arrived in hospital, and once she'd been in hospital she started vomiting, and what she was vomiting was faeces. So she was under the surgical team who were looking at, has this woman got a bowel obstruction? So what she had was a CT thorax abdo-pelvis. They didn't find any evidence of bowel obstruction, her bowel hadn't perforated, but what it did show is that the large bowel had severe kind of fecal impaction. So this is a woman who's extremely constipated. At the point of the referral to the mental health liaison team, she is still receiving her clozapine. The team on the surgical ward had prescribed her lactulose and Movicol. She'd had a phosphate enema, but she still hadn't opened her bowels. And the reason for the referral was that the team were asking about how and when to give her clozapine. So some of the things that we'd have to consider for a case like her. The first things first would be the impact that clozapine itself is having on this woman's bowel. So what we know for clozapine is that it's linked to GI hypomotility, which means that clozapine itself can decrease the contractile forces of the bowel and can lead to slower transit through the bowel. So it leads to chronic problems like constipation. And I've put some of the symptoms there of GI hypomotility, including a distended abdomen, an acute abdomen, vomiting, diarrhea. Another consideration is that clozapine can lead to a condition called paralytic ileus. So paralytic ileus is the complete absence of motor activity of the bowel. So the peristaltic waves are not getting transmitted at all. And what happens is that fluid and gas will collect in the intestine, can also affect so it's predominantly the small intestine, can also affect the colon and the stomach. And as that accumulation of the fluid and gas happens, the abdomen becomes distended, patients vomit, there can be a complete absence of bowel sounds and absolute constipation. And untreated paralytic ileus can result in death. So paralytic ileus itself would be a contraindication for clozapine. The other things to think about is that gastrostasis. So the bowel isn't working properly, and we know that when we're toxic with clozapine, that can cause constipation, but also vice versa. The constipation, the gastrostasis can also lead to toxicity. So again, for her, we've got to think again, is she in that toxic range? Has she got any signs or symptoms of toxicity? What we know from what I told you at the beginning is you've only got 48 hours to decide what you're doing with clozapine, after which you're going to have to retitrate from the bottom dose. The other consideration is how's the patient? You know, what's her current mental state? Is she having a relapse because of everything that's happening with her physical health? And the final consideration is the fact that she's vomiting, and you've got to take an oral tablet with clozapine. So how are you even going to get that into her if you did want to give it? And what we know is that clozapine can be crushed and mixed with water, and there is also an unlicensed IM clozapine. It's available from the Heartlands pharmacy. There's a very specific policy for its use because the dose isn't equivalent for the IM. So here's what we did. We withheld the clozapine initially for 24 hours, but after that it was ongoing actually because this woman just deteriorated. We also stopped her procyclidine and amisulpride. Procyclidine is anticholinergic. It will contribute to constipation. Amisulpride, as you'll see with all of the antipsychotics, will also have constipation on its side effects. We did liaise with the pharmacy to make sure that we could get the IM clozapine were we to want to use it. We did check the clozapine levels to make sure that she wasn't toxic and they were within range. We asked specifically for the surgical team to come and give us a clear idea of whether they thought this was paralytic ileus, because after that we would just know it was contraindicated, and they came and they said that it definitely wasn't paralytic ileus. Sadly for our lady though, she's vomiting feces and she aspirated on this, so she ended up with an aspiration pneumonia. She had to go to intensive care. It's during the pandemic, she had COVID pneumonitis, and in the midst of all of this, probably very predictably, she relapsed with her catatonic schizophrenia. So she became mute, immobile, increased tone, peculiar motor movements. I remember going and she was kind of clapping and clasping her hands repeatedly. So all those features of relapse. And I guess we could expect that clinical deterioration in keeping with, she's stopped a medication that she's been on for many years, but she's also physically very unwell. So what were going to be her best next steps? Because we didn't want to put her back onto clozapine because it had led to such life-threatening gastrostasis and constipation. Equally, we can't just leave her untreated. She's really mentally unwell, and as she physically improved, the focus goes obviously clearly onto her mental health. So I asked Heartlands Pharmacy, have always been very helpful to us. They did a literature search to kind of look at what would be the best next steps for someone with catatonic schizophrenia, but also this severe side effect of clozapine. Unfortunately, constipation is an anticholinergic side effect that can be caused by all the antipsychotic drugs. Clozapine is the worst culprit, and as I've put on there, it's listed as very common, which means that more than 1 in 10 patients will be effective. The recommendations are around increasing fluids and fibre intake, stopping any anticholinergic medications, prescribing of laxatives, but it's hard from the literature you've got to make a good choice of what's the best next drug for this woman. And in fact, a Cochrane review found that there were no studies to guide in the management of antipsychotic-induced constipation. So it was kind of making your best next guess, really. What did actually happen with Zelda is that we prescribed her aripiprazole. That was gradually titrated. She was detained under the Mental Health Act, and she had a lengthy admission over to the Heartlands Hospital. But these were kind of the learning outcomes that I wanted to pull out from this case. mainly that constipation is a very common adverse effect of clozapine. It often gets neglected. It can lead to obstruction, paralytic ileus. It can often persist. And again, think about that toxicity. If someone should be opening their bowels at least 3 times per week if they're prescribed clozapine, otherwise we're in that risk zone for toxicity. And that was just a brief slide on some of the common catatonic behaviours for anybody who was kind of unfamiliar with that condition. So I'm going to try and race through the last case. I've got a few more minutes. So Peter is a 67-year-old gentleman. He's got a diagnosis of paranoid schizophrenia. He's known to community teams. Again, a very long-term patient. He's been on clozapine since I think the 1980s, and he's on 300 milligrams a day. He's not a smoker. He's also again prescribed procyclidine alongside for EPSCs. So he presents after reporting an overdose. So he's discovered by a friend who's kind of I think he's failed to answer the phone to his friend, the alarm's been raised, they've attended the property and he's said that he's taken an overdose, and this was in response to being the victim of a financial scam. He's got a pattern of this in the past. When he's unwell and he relapses, he hears voices, he becomes psychotic, and he's taken overdoses. So in the emergency department, there's lots of features with Peter of kind of psychomotor retardation, poverty of thought. He looks severely depressed, struggles really to engage in the conversation, but is able to say that he thinks that clozapine is fake, and he says that he's not been taking it, but we've got no one to corroborate if he has or he hasn't. Equally, has he just taken an overdose of it? It was very unclear. So overall, our kind of suspicion was that he was having a relapse of paranoid schizophrenia, but there were prominent features of psychomotor retardation and catatonia. Now, because of the uncertainty about has he been taking clozapine or not, he was monitored in the emergency department and tox-based consulted so that he had the baseline monitoring if it had been a clozapine overdose, and he had serial ECGs. He had his bloods, including his CK, checked, and they were within range. After the 12 hours kind of observation, he had a mental health act assessment and was detained on Section 2. Move over to the Heartlands Hospital, and I guess it's difficult because we don't know where we are in that 48-hour window of clozapine with this man. So what they noted on the ward was that he gradually had just become worse than that picture I've given you in the ED. He became mute, he was not responding, and he stopped eating or drinking. So the working diagnosis on the ward was that he'd got a catatonia that had been induced by a sudden cessation of clozapine. There was prescribed lorazepam for catatonia, and he also then restarted his titration schedule of clozapine. So he had 2 doses at that bottom starting dose. However, within 2 days of those doses of clozapine, he developed a temperature, and his temperature was over 38. I want to say for weeks. It went on a very long time. He was tachycardic, he had lead pipe generalised rigidity, he had a complete change in his mental state, and he had raised inflammatory markers. So it was an urgent transfer back to Royal Stoke, and he had multiple seizures in the emergency department. So initially he was prescribed IV antibiotics, but also acyclovir, thinking about pneumonia, but covering him for did he have encephalitis or meningitis. And he had a host of sort of neurological investigations, including EEG, CT, MRI, lung puncture. Didn't really show much up. What we did have, though, was that his creatinine kinase, which had been normal at the point of first presenting, was now 1,329 by the 9th of March, and it carried on to rise after that point. Peter himself is unrousable, tachycardic, rigid, very high temperature. So what we were thinking for this gentleman was someone who's had clozapine, it stopped suddenly, it maybe stopped at the point of an overdose, then he's had a restart, then he's started to decline, he's become non-verbal, he's spiked temperatures, he's increased in tone, and alongside that we've got a sudden rise in CK in line with all his escalating symptoms. So our working diagnosis would be neuroleptic malignant syndrome. Alongside, have to consider malignant catatonia. But if we focus on NMS, and that has to take priority on all the guidelines, if you're thinking between NMS and catatonia, NMS will trump it because of the life-threatening urgency of it. Neuroleptic malignant syndrome is an idiosyncratic, life-threatening response to the dopamine blockade of antipsychotics. It happens in up to 1% of all patients treated with antipsychotics, but there's also case reports of it occurring with antidepressants, with lithium, and with valproate. The risk factors for developing NMS are being male, dehydrated, hypothyroidism, any organic brain disease, so things like Parkinson's disease, alcohol dependence. Younger males are more likely to develop NMS. Older adults are more likely to die of NMS, and we're in that older category. So that was just a quick slide kind of giving you a bit of a mnemonic on NMS, so the key features being the temperature, the encephalopathy basically describing that altered mental state, that you get autonomic instability, so changes with fluctuating pulse and blood pressure, an elevation in CK, and that generalised rigidity. There are, as I say, differentials, including malignant catatonia for this gentleman. Complications of NMS can include renal failure, aspiration pneumonia, rhabdomyolysis, cardiovascular collapse, arrhythmia, seizures, death. A very severe condition. And Peter, sadly, developed almost all of those complications of NMS. He had seizures, he had renal failure, he had aspiration pneumonia, his GCS went down to 4, he had to go to critical care, he was intubated, ventilated, and he was on that unit for some time. And this was in pandemic, no visitors, really difficult to go and assess him, to see him, really difficult for his family. I remember bringing them most days to kind of give updates. So essentially, he's tubed, he's ventilated. Later on, he was weaned and he had a tracheostomy with a speaking valve, but even with that in, no verbal response from him. He's rigid, the fever has remained high. Clozapine's obviously been completely stopped. And what we started for treatment for NMS, obviously ICU are doing all their support in terms of fluids and cardiovascular support, cooling, etc. But alongside that, we prescribed him Clozapine, and it's high dose, so it went up to 12 milligrams in 24 hours. That did help with the rigidity, so we were able to get some normal tone in his limbs. There was some spontaneous movements of hand and feet once he was on that. But even with that very high dose of Clozapine, with all the full intensive care support, with cessation of those antipsychotics, his response remained absolutely minimal. So what we did is we had discussions with the family, also the intensive care team, the community team, we had the ECT team at the Heartlands, we even involved the ECT college lead for the country, Professor McShane, to decide about giving this gentleman ECT. And in the end we did do that, so we started him on ECT, carrying the machine over from the Heartlands and giving it on the intensive care ward at Royal Stoke, which was a feat in itself. But essentially, I'm happy to say that he did make a good response with ECT. Again, an unusual case, I've probably not got time to go through it all, but we gave ECT under the Mental Capacity Act initially. Again, during the COVID pandemic, extremely difficult to get second doctors to even come in the hospital to engage in a mental health act assessment. So we did, after discussing with the national lead, we gave it under the Mental Capacity Act for the first 2 treatments. And the idea was if he showed any response, then we'd go for a mental health act assessment, which we did, and we detained him on section 3, and he continued with ECT. I'm pleased to say that for Peter, he completed 10 sessions of ECT, he did make a really good recovery, and actually in the longer term, he was able to reinitiate Clozapine and titrate it without any adverse effect, back up to his, not as high as his start dose, but he went back up to 100 milligrams twice a day. So the learning points from Peter that I wanted to kind of draw your attention to were that NMS can occur at any time, but be aware of any recent increase or decrease in antipsychotic dose, be alert to the signs and symptoms of that condition, and remember that mnemonic because it's helpful. So hopefully in sort of just over 30 minutes, we've had some interesting Clozapine cases. I wanted to draw your attention to those kind of final learning points. So remember, you've got that window of 48 hours before you've got to retitrate if people miss their doses. Remember that NMS can occur at any time. Beware of the bowel, monitor the bowels, don't forget about them. Beware of smoking status and that your dosage may need to drop by 50%. Beware that when we take a level, it needs to be a trough level, and let's have that awareness of the normal range and those signs and symptoms of clozapine toxicity. And that's my last slide. So I don't know if anyone's got any questions or comments. I'm mindful of time as well, that I've slightly gone over. And if anyone spotted my famous cases, any guesses? Yes. Yes. She's a difficult one. Zelda Fitzgerald. So she was the only famous woman I could find who's had schizophrenia. So she's the wife of F. Scott Fitzgerald. Yes, well done. Were there any